Good morning to you all. I'm Greg Fitz, and I have the pleasure of introducing Dr. Mayosi as a keynote speaker this morning. First, I'd like to add my welcome and sincere appreciation to everybody in the room for this Global Health Symposium. 2 years ago, when we were looking at this with some in sort of a list-making sort of an exercise, we discovered that there were well over 100 individual projects, educationally or research, with our faculty and people around the globe. And this was both a surprising and a delightful observation, but it wasn't organized in a really coherent manner. And so this created an opportunity on this campus for an Office of Global Health to really bring some structure and momentum to this effort, which we really believe in. And it also pointed out that UT Southwestern couldn't do this alone. And other institutions in Dallas and around the state have expertise in domains that we do not. And so from the standpoint of this institution, but also our partner institutions, this symposium is a way of recognizing that, and we think drawing into focus some of the relationships that we all need to be working on and developing over time. So I'm very excited about what this symposium represents, and very much appreciate everyone's attendance. As Dan has indicated, we are about to sign another more formal relationship with the University of Cape Town. And Professor Mayosi, as professor and head of the Department of Medicine at that institution, is in a position to provide us with some of this help. We're going to learn an enormous amount from this interaction. For those of you who are younger, who seem to be most of the people in this room, the University of Cape Town is a fantastic institution. In my own area in liver diseases, when I was in training in the 80s and such, a lot of the literature of the best in the world in clinical care of liver diseases was coming out of the University of Cape Town, and the same in cardiovascular diseases. And in this room last week, we celebrated our 5th Nobel laureate. Well, the University of Cape Town counts amongst its graduates 3 Nobel laureates. And so this is a wonderful institution that's positioned in a place and in a time. They have their own challenges, which I suspect we'll hear some about, but it's positioned in a place and a time to be an ideal partner for some of the things that we really are looking forward to from an academic and an educational perspective. Professor Mayosi is a cardiologist and a genetic cardiologist, and has contributed enormously academically, but he's also been a real leader in the country as president of the South African Heart Association and many other roles. And so this is an enormous institution that's every bit as complex as our own. I noted in his background that he recently received the Order of Mukambwe in silver from President Zuma for excellent achievements in medical sciences. And so this is a recognition that both he in person, but also the institution that he represents is going to be a wonderful partner for UT Southwestern and for the state of Texas. So we are delighted by your willingness to attend and look forward to the week. Thank you.
Dr. Fitz, colleagues, friends, and ladies and gentlemen, it is a singular pleasure for me to be standing in front of you this morning. It is a pleasure because it represents a culmination of work that I've been doing with one colleague in this institution, Dr. Tawanda Gumbo, who first visited the University of Cape Town in about 2008 as a Mellon Visiting Fellow funded by the University of Cape Town. The reason that is so is because I had started working on a project on pericardial tuberculosis. And being a mere cardiologist, I knew very little about infectious diseases. So I cast my eye around the world to identify a person who can help me to deal with this problem of pericardial tuberculosis. And the name of Tawanda Gumbo came up, and I contacted him. He visited Cape Town. We supervised a student together. We've written a paper together. We've written a grant together. So it is, I think, appropriate that I should visit here. And I'm very, very delighted that on Wednesday, my whole university, together with this university, will be signing an agreement that will lead to an even greater collaboration. What I'm showing you here on this slide is a photograph of Groote Hospital, which is nestled here at the foot of Table Mountain. This is on the side of Table Mountain in Cape Town. That is the road to the center of Cape Town from the airport. And what you see in the corner here is in fact the medical school. And far away there in the distance is the real University of Cape Town. And this complex represents the teaching university complex at Cape Town. Now a close-up view of the hospital shows you where the Department of Medicine is located. It is located in the old part of Groote Hospital. So this building was built around 1938, and then about 50 years later, the new building was set up here, the new Groote Hospital. I think to many in the audience, they will be aware that in this old hospital, one of the most famous operations in the world took place, which was the first human heart transplant, which in fact took place in the theater here on the first floor of this building in 1967, on the 3rd of December 1967, and it was Christian Barnard who performed that operation, a South African surgeon who had trained, in fact, in a number of US medical schools before coming back to Cape Town to initiate open heart surgery from the late 50s. He was a pioneer in many techniques of surgery leading up to the first heart transplant. What is less well known is that the same hospital has in fact contributed to one of the great inventions of the last 100 years when it comes to imaging. And that invention came about because of this man, Alan Cormack, who is a South African, who was a physicist, in fact, who taught at the University of Cape Town Medical School. And in the mid-50s, he was asked by the doctors at Groote Hospital, because he was a physicist, to come and be the keeper of the isotopes, because the law required that a physicist must be the one signing off the isotopes as they are delivered to the radiology department. Now, it was Cormack around 1955 who saw the way in which radiology was practiced, which was a straightforward X-ray of the chest, and he figured that it may well be possible to take X-rays in more than just one dimension. He thought of the idea of computed tomography, and in fact in 1955 wrote the mathematics that led to the solution of this problem, and in 1961 built the prototype of the CAT scan in the Groote Hospital building, which was a small machine at the time, and it took the English engineer Hounsfield to take that idea, that concept, and build it up in the machine. And CT scanning now has become a central part of our work, and Cormack and Hounsfield, as you know, were awarded the Nobel Prize for Medicine and Physiology in 1979 for the invention of the CT scan. It is probably the only Nobel Prize, really, that arose out of work that was done in the building of the university. I think it has been mentioned that there are 3 other students of the University of Cape Town who went on to win Nobel Prizes, but they did the work outside Cape Town, not in Cape Town. So I learned that the University of Texas Southwest has not just one Nobel Prize to its credit, but several. And this is part of the reason this relationship is so attractive to us, because we want to learn about how to conquer the formidable problems of science and medicine so that we can create a better world. I bring you greetings from colleagues in my Department of Medicine at Cape Town You see them here in the photograph. These are the consultants in the Department of Medicine. I was talking to Dr. Joe Hill just now about the numbers of cardiologists in the division of cardiology. He says there are 70. So there are as many cardiologists at UT Southwest as there are consultants in the whole Department of Medicine. Now, we still have an old Department of Medicine, which is made up of cardiology is still in medicine, still part of medicine. We have about 5 cardiologists in our department. And what I'm showing you here are the various divisions of the Department of Medicine. It is a fully fledged unit that has got activity in almost all the subspecialties of medicine, including GIT and hepatology. I noticed that at UT Southwest, the requirement for higher office, such as dean or president of the school, is to be either a GI or a hepatologist. And we have quite a few of those at the University of Cape Town, and they continue to pioneer areas in clinical medicine, such as transplantation now in people who are HIV positive to people who are HIV positive, where we're using donor organs from individuals who are HIV positive and recipients who are HIV positive. As you can see, among the 20 divisions of the Department of Medicine in Cape Town, which are the clinical units, there are also major research units that are attached, such as the Hatta Institute of Cardiovascular Medicine, where Lionel Opie works, who will be known to many who are working in that area. We work in areas of leukemia. We also work in drug development, as well as in areas of HIV and TB. And each of these units are fairly significant units with about 50 people working in the units, so much so that overall the Department of Medicine in Cape Town would have about 500 people working in various activities. And we stand ready to engage with colleagues from here, from UT Southwest, as we move forward. And the Department of Medicine is just one example of, there are other 10 departments of similar size and similar scope of activity, which, although small, but relatively effective and efficient, we see ourselves as lean and mean and ready to engage with the world. Now, the brief, of course, of my talk today was to give you some idea of what are the forms of, what are the health problems that we experience in South Africa and in Africa in general. My area being cardiology, I am going to confine myself to matters of the heart. Although initially, I think I need to share with you about the pattern of disease in South Africa. And I think this slide, which gives information on age-standardized mortality, captures the nature of disease that afflicts South Africans and that also affects Africans more generally. It is a pattern of disease that has now been called the quadruple burden of disease, where you have a contribution by injuries, by non-communicable diseases, HIV and AIDS, as well as other conditions such as perinatal illnesses. And what I'm showing you here are the patterns of mortality in the various suburbs of Cape Town. And we've put these suburbs along a gradient of socio-economic class, from the poorest sections of Cape Town to the wealthiest components of Cape Town, so from Khayelitsha to Constantia. And what we're showing you here on this axis are the deaths per 100,000 in Cape Town, and the proportion of deaths. And one of the key ideas that are shown by this slide is that when you go to the poor areas of Cape Town, such as Khayelitsha, you see that that's where the heaviest burden of disease falls. And this burden of disease is in fact a mixed burden of disease. It's not a burden of disease that is just characterized by infectious illnesses. I think people from outside Africa often think of Africa as a problem of infectious disease. That is no longer so. It is in fact a complex situation where you have a number of colliding epidemics. The epidemic of HIV and AIDS is quite significant, and that epidemic of TB is quite significant. But you have a large, if not larger, contribution by non-communicable diseases and injuries. And it shows the well-known point that illnesses and disease have their greatest accent on poor people. People who are more wealthy are less susceptible to illness and disease in general, which illustrates and puts into sharp focus the way in which research money is spent globally, in that 90% of the research money in the world is spent, in fact, on a population that is similar to the people living in Constantia and Cape Town, and only 10% of our research dollar goes to the people who needs it the most. And I think it is initiatives such as this in global health that will seek to shift this balance and make sure that we address, we target our energies and our funding to where it is needed. When we have looked at what has happened to mortality among South Africans over a period from about 1999 to about 2006, we see actually a very interesting pattern. And what I'm showing you here are cardiovascular deaths over time, and the cardiovascular deaths over time are disentangled in terms of cause. We've been able to do this because the death certification system in South Africa now has improved, so much so that we can vouch for a reasonable accuracy of these particular patterns. I think one can see that when it comes to certain conditions, such as stroke, which you see here, such as ischemic heart disease, which is represented here, you see an interesting pattern where there was rising mortality until about the mid-2000s. And from about the mid-2000s in South Africa, there is, in fact, falling mortality from stroke, from ischemic heart disease. And when we have analyzed deaths from other conditions that are related to smoking, such as lung cancer, such as cancer of the esophagus, as well as deaths attributable to chronic obstructive lung disease, we see a pattern, in fact, where there is falling mortality, probably related to what has happened in the general population to smoking rates. Smoking rates in South Africa have, in fact, been halved from about smoking among males of about 45% in the late 1990s to smoking rates of nearly 20% among males in about 2003. And of course, I think people know that reductions and changing in smoking can translate fairly rapidly to changes in mortality in populations. This has been seen in quite a number of countries in other parts of the world. But this promising trend when it comes to mortality from non-communicable diseases is, in fact, not consistent. Because when you look at deaths attributed to chronic kidney disease, there has been, in fact, a nearly 70% increase in those types of deaths. We think, in fact, one of the major contributors to this is chronic kidney disease related to HIV infection. The problem, of course, of increasing body size among South Africans, which applies to the Americans and people all over the world. The problem of obesity is on the increase, and you see it in its translated to deaths attributable to diabetes, which continue to increase relentlessly, indicating one of the major areas of intervention that we must focus on. When it comes to heart diseases, if I can just go back a little bit, one does see that there's a mixed picture here. For ischemic heart diseases, I said there was a change in the pattern of mortality in both males and females. But when you look at the group that are said to be ill-defined forms of heart disease, and this relates to non-ischemic forms of heart disease such as pericardial tuberculosis, such as rheumatic heart disease, the increase, in fact, continues, as well as when you look at hypertensive heart disease. Now, in my own area of interest, which is the area of heart failure, when one looks at the pattern of heart failure in all of sub-Saharan Africa, one actually sees a very, very interesting pattern. Whereas in other parts of the world outside Africa, the major cause of heart failure is, in fact, ischemic. Ischemic heart disease causes 90% of presentations of heart failure among adults outside sub-Saharan Africa. Sub-Saharan Africa is actually very, very interesting. It's an exception. It's an exception in the whole world, in that the major causes of heart failure in the sub-Saharan region are, in fact, non-ischemic. The major culprits being hypertension, rheumatic heart disease, as well as the cardiomyopathies. And when you've taken those three together, they explain 70% of all cases of heart failure. Cor pulmonale is important. This is right heart failure due to post-TB lung disease or smoking-related lung disease is very, very important. Syphilitic heart disease has been replaced by HIV-associated heart disease. Pericarditis is important, explaining about 3% in the whole region, but in South Africa, in fact, 10% of presentations with heart failure to hospital are due to pericarditis. You can see that ischemic heart disease in our backyard is not that important, still explaining about between 3 and 8% of causes of heart disease. Of course, in the more urbanized areas around Johannesburg, the proportion is about 8%, as shown in the studies by Karen Sliwa from Johannesburg of the heart of Soweto, but the average is still relatively small. We have historically been interested in the problem of pericarditis, and I think for the purpose of this audience, I just want to take that issue, lift it up, because it illustrates quite a number of issues that have arisen with respect to heart disease. And pericarditis is a problem that is associated with an effusion. This is a short axis echocardiogram of the heart. This is the heart. It's cut like a loaf here. And what you see here, this black hole here, this space between the pericardium here and the heart is in fact a large pericardial effusion. Large pericardial effusions due to tuberculosis, so these are chronic effusions that have arisen over several months, are in fact a major differential diagnosis in a patient presenting with heart failure in our environment. The main culprit for this is tuberculosis, so that 70% of those cases with effusive pericardial disease are due to tuberculosis. More recent studies from other parts of the world where TB is no longer endemic indicate that TB is in fact explains a very small proportion of cases with large pericardial effusion. Large pericardial effusion in other parts of the world is usually idiopathic. If it is not idiopathic, it's usually malignant or maybe due to autoimmune disease or perhaps purulent infection. But in our environment, TB is a major cause, and TB having such a major burden in our part of the world with 10 million cases in the year 2000, associated with a lot of deaths, is, as you can see, probably the most important cause of pericarditis in the world, because we know that between 1 and 8% of cases of TB present with TB pericarditis, and those who are HIV infected much more commonly than those who are HIV negative, which means worldwide we probably have nearly 1 million cases of TB pericarditis in the world. And yet, in terms of research, you might think the problem does not exist because there are probably only 2 or 3 groups in the world that are looking and examining ways of dealing with this particular problem. And as I said, in our environment, 1 in 10 of cases with heart failure have pericardial tuberculosis. Something interesting has arisen, of course, since the advent of HIV infection. HIV infection has changed the way in which many conditions present. We've had to rewrite many textbooks because of HIV infection. Many of the things that we taught about conditions that present have had to be re-examined. And that also applies to TB pericarditis. We've observed an entity that we have called HIV-associated TB pericarditis. As you may have surmised, HIV has been noted, has resulted in TB pericarditis being a much more common condition. And as I say, explaining 1 in 10 of cases of heart failure in our environment. Studies that we've done with colleagues over the past 5 years in the Sub-Saharan African region indicates that HIV-associated TB pericarditis is in fact a more serious disease. It's a much more severe disease. These patients present with higher grades of shortness of breath. They tend to have much larger hearts. And whereas before, we used to teach that the electrocardiogram in the patient with pericardial tuberculosis is abnormal in a non-specific way, abnormal enough to point to the heart as the source of the problem. What we have observed in these patients is that, in fact, the ECG of the patient with HIV-associated TB pericarditis looks angry. It is a pericarditic ECG with ST segment elevation, indicating that the disease is not just a TB pericarditis. It is, in fact, a TB myopericarditis. No wonder these patients also have an associated left ventricular dysfunction. I think some people, who've seen TB pericarditis in the pre-HIV era, they will know that these patients would present with large effusions, with a heart in that effusion that is bouncing merrily. Whereas in these patients, the heart is lazy, in addition to the large effusion that exists, indicating that it is not just a disease of the pericardium, it's a disease also of the myocardium, underlining the extensive nature of the disease that presents. It is no wonder then that people with HIV-associated TB pericarditis have a much higher mortality than those who are not HIV infected. But a surprise finding of our observations have been that these people, if they survive the early phase of their TB pericarditis, tend to develop less fibrosis, less constriction. This is the example of an ECG that we used to teach that it does not occur in patients with TB pericarditis. This is the classic ECG of pericarditis, where you see widespread ST segment elevation in all of the leads of the heart that do not follow any particular territory. In addition to that, you see the pathognomonic PR depression there in one, and there's nothing else that causes this ECG except pericarditis. So we used to teach that you don't see this in TB pericarditis in the pre-HIV era, but now, as I say, about a third of patients with HIV-associated TB pericarditis present with an ECG with this type of abnormality. When we have followed patients with TB pericarditis over time, this is a study that I've done with colleagues in many hospitals in Sub-Saharan Africa, in which we have recruited about 200 cases that we followed over 6 months. This study, in fact, is called the MP study, which stands for the investigation of the management of pericarditis in Africa. Those of you who have some knowledge of history will know that the MPs actually refer to the Zulu battalions who vanquished the great army of Queen Victoria in the late 1870s. And of course, it matters what you call your study. We call the study MP because we think this problem needs to be solved, and needs to be solved in a decisive manner, such as what was delivered to Queen Victoria's armies by the Zulu MPs. What you see here on this slide is that if you follow patients with TB pericarditis over time, so these studies now were done in the 2000s, closing this study around 2005, you see that the mortality overall is about 26%. In people who do not have AIDS clinically, so it was a clinical assessment of immunosuppression, the mortality was 70%, but in those who have a clinical evidence of AIDS, the mortality was 40% at 6 months. Now, we are referring here to people with a median age of about 33 years, right? And those of you who are cardiologists in the audience will realize that this is a disaster, because people who study ischemic heart disease outcomes now are fighting over reducing mortality from 3% to 2.5%. And they tell us about these big changes in outcome with these relative risks that they are studying. Here, you're dealing with a condition that is associated with a mortality of 40% in 33-year-olds, right? An outcome that's almost similar to cardiogenic shock in patients presenting early. So clearly, a major problem. And what has happened with the advent of HIV is that there has been a reversal in the fortunes of TB pericarditis. We all know that before anti-TB medication was introduced, before 1940, if you had pericardial tuberculosis, you were going to die in about 100 days. So that there was 100% mortality associated. Streptomycin was introduced, and by about the 1970s, before the introduction of rifampicin and INH, the mortality was sitting at about 40%, but by about the 1980s, where you had dual-sidal drugs for the treatment of TB, the mortality, in fact, had come down to a respectable at 10% for this particular condition. So HIV comes in, and we're saying now the mortality in these patients is back up at about 26%. I also mentioned that an observation in these studies that was rather interesting was that suggested that HIV protected you from developing constriction at about 6 months. So when we followed these people, we had 185 to start with. 121 were available for for study at 6 months. And we just asked a simple question: what was the frequency of constriction in these survivors of TB pericarditis? And then we stratified the groups by either clinical AIDS or by those who were tested for HIV. It was quite interesting to observe that the patients, and perhaps this is a group of interest, those with definite serological testing, in people who were HIV seronegative, HIV seropositive, we did not observe a case that had developed constriction. And in those who were seronegative, constriction had developed at a rate that is known. We know that a quarter of patients with TB pericarditis develop constriction at 6 months. And my immunology colleagues told me that they are not surprised, because the CD4 count, CD4 cell, is actually quite central in the genesis of fibrosis. And I want to suggest that if there are some fibrosis scientists in this university, this is a model that we can use to study mechanisms of fibrosis and try to understand how the immunology of fibrosis works. So this is another way of representing those data, showing that HIV infection might, in fact, if you survive, protect you from developing fibrosis. Now, I have shown you that the burden of disease among South Africans is a quadruple burden of disease, in which particularly poor people are susceptible to injury, to non-communicable diseases, to communicable diseases. I've also shown you that when you look at heart disease among the people of South Africa in particular, it is actually largely non-ischemic, particularly when you look at causes of heart failure. The question, of course, is why this particular contrast? It is the answer to this lies to a well-known epidemiological fact. And that epidemiological fact has been now characterized by the famous words of the epidemiologic transition, which in this example of Korea follows a very, very simple pattern, whereby you can see that in Korea in the 1930s, the contribution of infectious diseases, as represented by this diamond here, as well as diseases of the respiratory system, which are infectious diseases, were much higher than circulatory disorders as well as cancers. And the remarkable thing, of course, in Korea is that between 1936 and 1996, just over 2 generations, you see this dramatic change in the pattern of disease, with infectious diseases coming down and the chronic diseases, the chronic circulatory disorders and cancers being major contributors of mortality. It is a very, very neat transition that is taking place, and it has happened indeed in many countries of the world. And of course, in the early 60s, Ghana was almost at the same level as South Korea in terms of development. But the unfortunate thing that has occurred in Sub-Saharan Africa is that Sub-Saharan Africa is one of those regions in the world that has not just remained still in terms of development, but has in fact gone back in development, so much so that the transition in Sub-Saharan Africa is a complex transition that is characterized by both a high rate of infectious diseases and an emergence of chronic diseases. It is a complex picture that is extraordinary and that has not been observed actually in human history. People try to reduce the problem of Sub-Saharan Africa to this situation that will sort itself out into non-communicable diseases and communicable diseases. That ain't so, and it will not be so for quite a while because of the coexistence of extreme poverty and extreme wealth in more or less the same conditions. And this is key in terms of the research agenda that we set for engaging with Sub-Saharan Africa. That unique epidemiological, those unique epidemiological features of largely non-ischemic disease point out where we should put the accent in terms of our work on addressing high blood pressure, rheumatic valve disease, cardiomyopathies, pulmonary, as well as TB pericarditis. And indeed, what makes the problem urgent is that these are conditions of relatively young people versus these diseases of the cardiovascular system in particular being diseases of old age. And there is still an ongoing impact of infectious diseases on these chronic diseases. So that the challenge in Southern Africa is not so much this choice, this false choice that people often make between non-communicable diseases and communicable diseases. It is in fact a challenge of understanding the interaction between infectious and non-communicable diseases and finding ways of dealing with that. So the appropriate agenda then has to be focused on eradicating these neglected infectious diseases and post-infectious diseases that are still with us. And of course, I have said that these cardiovascular risk factors are also with us. You saw the rise of obesity, the rise of diabetes, the rise of blood pressure. But the challenge really is it's more about primordial prevention in sub-Saharan Africa because atherosclerotic disease has not yet become established. You do have the risk factors. The cholesterol still remains relatively low, which is why atherosclerosis has not become established. So that the challenge of prevention is that of primordial prevention, of prevention before atherosclerosis sets in, of primary prevention. And that's where we ought to be focusing our attention much more proximally than people have done. And we need to do that by developing innovative strategies for making sure that we deliver care that is preventive, that is at all levels in our system, and not only focus, of course, on what has happened, the vertical programs that have been promoted by many funders from the North that only fund HIV and AIDS or malaria or this type of infection. We need to move away from that and move towards a much more integrated way of tackling disease. Because as I've pointed out, the people of sub-Saharan Africa are not only suffering from these diseases of infection, but they also suffer from diabetes and hypertension. We are not, of course, waiting in sub-Saharan Africa for people to arrive. We are active in doing work, and there are many, many collaborative studies, some with people from other parts of the world that are tackling these particular problems. And the one that I have referred to that we're involved with is called the IMPI study. And we are collaborating with Dr. Gumbo here in taking that study to higher levels. We are also having a movement that is tackling the problem of rheumatic heart disease, which is called the Stop Rheumatic Heart Disease ASAP program, which seeks to use a comprehensive approach to deal decisively with rheumatic fever and rheumatic heart disease, and certainly make it history in our own lifetime. We are also having studies on heart failure, such as the registry called THESIS, which has been set up and is about, in fact, to report on its first, on its baseline paper very soon. And there are also population-based studies of endomyocardial fibrosis that are taking place in Mozambique and other parts of Africa. I'm sure people saw the report from Ana Olga Mokumbi from Maputo in the New England Journal of Medicine on the epidemiology of this condition that was published recently. And the type of engagement that we seek from people in the North is that engagement which says that, which identifies the problem that exists in Africa as I've painted it, but that also recognizes that there's activity that is going on there. It is not a blank space. You need to find out who's doing what and engage with people who are working and seek to build institutions in Africa, seek to build leadership in Africa, because it is African leadership that will, in fact, solve Africa's problems. Thank you.
Curious about other epidemiologic studies showing a pretty sharp rise in the incidence of cancers in sub-Saharan Africa. And I wonder if you'd comment a bit on the types of cancers that you're seeing and what that might suggest about the origins in Africa as compared to this country.
Yes, that's a good point. And it is a matter, in fact, that we have analyzed there was a Lancet report on South Africa, on the health of South Africans, and we did look, for example, at what is happening to cancer in South Africa. And it is a mixed picture. Clearly, Kaposi sarcoma is on the rise, and that's obviously driven by HIV as a main reason for that. And the other cancers that are on the increase, I'm talking now about South Africa specifically, cancer of the cervix. We have not got that under control. which is why we've called for human papillomavirus vaccination in adolescents as one of the interventions. The only types of cancers that appear to be on the decline in South Africa are the cancers related to smoking, such as, more directly, such as lung cancer, cancer of the esophagus, as well as cancer of the trachea. When it comes to cancer of the liver, early after the Mandela government took over in 1994, hepatitis B vaccination was introduced as part of the expanded program of immunization in the country. And there are indications that cancer of the liver is leveling off, and there might even be early trends suggesting a fall off in cancer of the liver. So there is progress that's been made, particularly with, as I say, smoking, as well as some of the vaccine preventable cancers where the vaccine is being deployed. We're seeing some progress. So those are data for South Africa. Data for the rest of the continent I am not very familiar with, and it may well be that there are some cancer people in the audience who have a much better grasp of what is happening to cancer in the rest of the continent.
I have a question about developing a more holistic and comprehensive approach towards eradicating disease and addressing disease in sub-Saharan Africa. HIV/AIDS has developed a very strong group of advocates at the local level, and they have made huge strides in getting more resources and attention directed towards the epidemic. But if you're advocating resources be more evenly spread to address, more diseases than just HIV/AIDS, what do you think are the political challenges and the backlash that might be had? Because even the Obama administration has advocated for a more holistic approach towards disease, especially in terms of foreign assistance and aid and things of that nature, and there's been a lot of backlash against that. And people with heart disease and diabetes don't necessarily have the same kinds of advocacy, energy, and groups that HIV/AIDS has. So what do you think are the challenges of that kind of more balanced approach?
Yes, I think you've touched on a very important problem, which we have called apartheid of a special type. That has arisen. Okay, I call it apartheid of a special type because my patients that I look after, the way in which they are treated by the health system differs depending on what disease they have. Now, I'm old enough to know that when I grew up in pre-1994 South Africa, it mattered, when you needed to get on a bus, it mattered what color you were, right? So if you were black, you got onto the bus for black people and so on. So there was differentiation and apartheid. That's now applying to the diseases that my patients have. The ones with HIV and AIDS, they've got their own counselor, they have their own social worker, their own pharmacy. They even go to a separate place, in the pharmacy to get their medicines issued. Someone is monitoring their uptake of medicines and so on. Whereas my patient with diabetes, they just get told you've got diabetes and they just take their chances. So that's untenable, right? Yeah, it's got to be sorted out. Now, I think everybody accepts that that's the way we must go. The fundamental problem, in my view, is money, okay? To provide that level of care for everybody, you've got to invest the resources in the health system. And we have said that we must not dismantle what has been achieved for people with HIV and AIDS. We must extend what has been achieved for everyone, for everybody. And to do that, we need new money. We need new resources to do that. Because if we try now to spread what we have, it's going to be difficult. And this is one of the great disappointments for me personally about the recent summit on non-communicable diseases, in that it did not come up with new commitments for resources to extend and create this integrated framework that we're calling for. So I think it's going to be important for all of the advocates, people working on HIV/AIDS, as advocates, people everywhere else, for us not to fight among each other, okay, right? Okay, but to find ways of working together to raise these resources that are needed to create the system. Because if that does not happen, the patients with HIV and AIDS who are living longer, who are developing these other diseases now, are not going to do very well. So it is in all of our interests that we work together to advocate for more resources to be put in and take the model that has been developed for HIV and AIDS and extend for everyone else. We need to create a united system and dismantle the apartheid system that exists in healthcare for now.
Thank you so much. I just wanted to ask you if you could comment a little bit more. You outlined some really interesting things in your talk and an agenda to move forward in research, especially in how non-communicable and infectious diseases are interacting together in Africa. So I wonder if you could comment a little bit more on how, as academic institutions in these separate countries, we can work more together, maybe comment on the current barriers you're seeing and how we can move forward. What's your vision for that?
So if I get a question well, you're asking how academic institutions where?
Well, like here and there,
Yeah. Good. Yes. No, I think that's a very good question. As I have said, firstly, we need to understand the agenda. We need to understand what the agenda is about. The big problem is that people in the north who have the money often set an inappropriate agenda, okay? They create what I call these straight jackets that don't fit anyone, okay? In terms of their funding agenda. Of course, they've got the money, and as they say, he who pays the piper calls the tune, So we can't quite run away from that. But it needs to be understood what the agenda is about. The agenda is an integrated agenda, right? That seeks to build health systems that will help people to have longer lives. We want to prolong the life of Africans. What has happened in sub-Saharan Africa is short of a disgrace on a global scale, where the lifespan of sub-Saharan Africans has gone back by 20 years, whilst everyone was watching, right? We are not going to solve that by tackling one disease at a time. We are going to solve that using an integrated approach. So that agenda needs to be understood and must be accepted. So that's the first thing. The second thing is to recognize that the Africans are doing something about their problems. And for people in the north to find out who are the like-minded people with similar interests that they can work with and help to build their capacity. The big problem we have is that people write these grants from the north, they parachute in, they build an institute next to the medical school, they take our most talented people to work for them, and there's no one left to build the institutions. We want to put a stop to that, okay, right? We want to put a stop to that trend. People must come and work with us. We know what the problems are, right? We need the resources, of course, both intellectual as well as financial. If we do those two things, one, understand what the agenda is about, two, engage with the people in Africa who are building and who are solving their problems, then we will get where we need to go much quicker.
I'll just affirm that to say the problems have to come in terms of solutions from Africa, and to please not come and build something and poach your people with big money when what's there in terms of intellect, potential solutions, and history is your work. I thank you. I want to ask, in terms of that, mechanisms. You've shown some publishing together, getting grants together, but I'm interested in practical, pragmatic mechanisms for people to come and work with you and help be part of the solution as opposed to being part of the problem. Thank you.
Yes. No,
one last thing. The call for an integrated approach, alas, is not what we've heard for the last, well, since Alma Ata, really. But you've made a compelling evidence-based call for that, and I just hope that that call is heeded.
Yeah, thank you very much. So there are quite a lot of practical ways of working together. And those are at quite a number of levels. The first level is obviously research, right? It's working on research, and I've outlined some of the challenges in research. And that would obviously be based on mutual interest. A person based here identifies another person with a similar interest based in Africa. And in the same way that we've done with Tawanda Gumbo, right? We identify a problem, we identify a student, we set up a project, we write a grant together, and we train. And in that way, we lead to the solution of a particular problem. So there is interaction in research, and one of the model funding arrangements from the North, in fact, for how that research can be done is what is called the Human Hereditary and Health in Africa Funding Initiative, which has just been supported by Dr. Francis Collins, as well as Professor Mark Walport, which seeks to use genetics and genomics research to solve Africa's problems. But the way in which that grant scheme is set up in such a way that the leadership is coming from Africa, the funding is going to Africa, and the work will be done in Africa, right? So that at the end of it, we're going to hopefully solve some African problems, build African leaders, build African institutions. So that's insofar as research is concerned, right? So I've outlined an example, a model of a funding arrangement, how it might work. There are all obviously engagements at other levels too. We're interested in training. We're interested in clinical training, both at the undergraduate and the postgraduate level. And the best model for doing so is for stronger institutions in Africa to work with weaker institutions in Africa. For example, in the Department of Medicine in Cape Town, we partner with the Department of Medicine in Freetown, Sierra Leone. Okay? Over the past 5 years, we have trained the first cardiologists for Sierra Leone. We've built the first ICU in Sierra Leone. We have started the first clinical trial in Sierra Leone. And how do we do that? We do that in partnership with colleagues from the North, right, who fund that kind of arrangement, which leads to us training doctors with Sierra Leone on the appropriate conditions, and they go back to Sierra Leone with funding from partners from Geneva, such as World Heart Foundation and so on. So that is the model that's going to work, all right? And colleagues from other institutions come and give of their time in our training programs so that we can achieve this, okay? So this is happening all on site, building institutions, building people, building programs, building health systems. So those are some of the, I've just mentioned 2 examples in research and in clinical training. That is the model of development that we are championing.